Okay, good morning, everybody. Welcome to Medical Grand Rounds. And before we begin, I would like to respectfully acknowledge that we are here located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. Now, we do have a few people in the lecture theater, but we're actually, Grand Rounds is remote because our speaker is from Toronto. And I'm delighted to introduce Dr. Fahad Razak, who is a general internist at St. Mike's Hospital. He's Associate Professor and Canada Research Chair in Data-Informed Healthcare Improvement at the University of Toronto, the Provincial Lead for Quality Improvement in General Medicine at Ontario Health, and Vice President Research at the Canadian Society of Internal Medicine. He co-founded GEMINI, the largest hospital research and quality improvement network in Canada, and has received over $80 million in grant funding as PI. GEMINI is used by an active community of more than 1,000 scientists, health system leaders. Dr. Razak completed a degree in engineering science and his MD at the University of Toronto and was the first physician appointed as the David E. Bell Fellow at Harvard University. He's a senior fellow at Massey College and on the advisory board of the BMJ. Notable recognitions include the inaugural CSIM National Award for Mentorship, Dean's Emerging Leader Award, and the President's Impact Award at the University of Toronto. He also received the CSIM New Investigator Award and the Graham Farquharson Knowledge Translation Fellowship from the PSI Foundation. Dr. Razak served as the Scientific Director for the Ontario COVID-19 Science Advisory Table and contributed to over 50 science and policy briefs that shaped Ontario's response to the pandemic. He was a member of the Federal Expert Panel on Science Advisory and Research convened by the Minister of Health and on the Transformation Subcommittee convened by the Board of the CIHR, by CIHI, to help guide their future directions. And we're delighted that he's going to be talking about using hospital big data to guide quality of care, learning from GEMINI. So without further ado, I'll hand it over to Dr. Razak. Thank you.
Thanks for the very kind introduction. What a delight to share our work with you today. We have worked with a large consortium of researchers. I'm just going to share my slides as I start speaking here. We've had the good fortune of working with a large consortium of researchers across the country. And I would say one of our key mentors as we've done this work has been Finlay McAllister, who I think all of you know very well. We've had the opportunity most recently to work very closely with Nish Panu on a vision of how to push this work forward. So the chance to share our work with the University of Alberta is a real privilege. I'm going to go to full screen, and I just want to make sure that slides are advancing. That's advancing okay. I don't see any dissent. Okay. So learning objectives for today is to describe our experience in creating large clinical data repositories. I'll add that in recent conversations with collaborators in Alberta, what we've admired is actually the significant advantages that you have over our province with a consolidated EHR in Alberta. A lot of the work that I'll show you today is what happens when you have to overcome the barriers of many electronic health records across many hospital systems. So I'm going to describe that process. That's my second objective, and then show how we are able to pivot its output towards health system crisis. I'll use the example of COVID, but as was mentioned, there's broader interest now federally, and last week we released what's called the Walport Panel, which is the only federal panel to look at part of our pandemic response. And it did highlight the need to further enhance the ability to harness health system data, because you don't know when that next crisis will hit, whether it's wildfires or flooding or an infectious disease. So I'll describe some of the work there. And the third example I'll highlight is some of the diverse applications within quality improvement, and really trying to think about how we can use this kind of data to influence frontline care and build towards a learning health system. In terms of disclosures, I have salary from our provincial quality agency, which is called Ontario Health, and also via the Canada Research Shares Program. So data and analytics have transformed the financial and other industries, but not medicine. And one of the questions I think we need to ask ourselves is, why is medicine such a difficult place to use healthcare data and analytics, and what are the barriers? We would argue that the principal barrier, and this is an interprovincial issue, but it's also for many provinces and even provinces with a consolidated EHR like Alberta, it can be the problem of fragmentation and standardization, even within institutions, within their own data holdings and within institutions that are part of universities, within large community hospitals. This fragmentation creates a very difficult environment. But it's not a problem that it hasn't been solved by other industries. So if you look at the left side of the slide here, we're highlighting the fact that other industries, whether it's the IT industry, internet-based sales, or financial industry, have worked on this problem of consolidation and have done so with highly sensitive data. I would argue that financial data is the requirements on protections of financial data mirror what we expect from health data. And so there is an ability to put this information together in a secure environment and allow it to be used for analytics, whereas hospitals largely continue to follow this siloed model. Our work in GEMINI has really been to try and address those silos, at least in the Ontario environment. And I'll highlight a proposal that we have at the end that we're working with on niche to think about an interprovincial model for how this could occur, how this could function as well. So GEMINI is now Canada's largest hospital data and analytics network. It's among the largest such networks in the world. And let me give you a sense of the kind of information that is increasingly digitized and why there's a lot of promise in trying to focus on health system data and clinical data when you're thinking about the future of analytics, QI, and other applications like AI as well. This is a case example, which I think would resonate with many of you. An individual admitted to one of our hospitals in the University of Toronto system, Sunnybrook Hospital, with melena, a history that includes prior bleeding, diabetes, atrial fibrillation, and he's on a blood thinner. Found to have a low hemoglobin at baseline, started on pantoprazole, admitted to a general medicine service, becomes sicker, hypotensive, and is in the ICU temporarily, transferred back, undergoes an endoscopy, diagnosis of an ulcer is made, discharged to rehab, but then is readmitted 14 days later with a fall. And in color here are all of the data points which are sitting within some digital repository somewhere within the system. They could be within a government administrative health data repository. They could be within lab systems. They could be in files that are generated for CIHI. They could be in clinician notes. But this information is sitting somewhere within the system. And our goal with GEMINI has been to bring all that information out and to standardize the format of it and to make it accessible for analytics. So what have we built on, and how is this data differ from what is generated routinely, for example, for CIHI? So on this pie chart on the right-hand side here in blue is information that's generated as part of a hospital's CIHI submission. It's the discharge abstract database or the ambulatory care repository, the DAD and the NACRS. It's cost data. This is the administrative data, which really gives us a snapshot of Canadians. I think all of you saw the reports from CIHI that were released this week about wait times, primary care access. This is that administrative data, which gives that incredibly important snapshot of what's happening across the country. But it doesn't give, unfortunately, a lot of depth on any individual encounter. And with the digitization of clinical encounters, the real opportunity has been trying to access data that gives that depth of information. And GEMINI's work has really been about that. It's been about everything that we highlight here in green. All of those clinical notes that are generated as part of clinical encounters now, electronic vital signs, all of the transfusion information, including the metadata, when it was ordered, who ordered it, how many units were given, what was the type and the matching, imaging reports, the medications that are given, also incorporating metadata such as was it intravenous or was it oral? What was the PRN dosing? The lab testing and the normal ranges, the physicians who are providing care every day of an admission, and even operational data that comes from what's called the admission discharge transfer system. So things like room transfer data, wait time in hospital for imaging, whether a patient was in a room that was near an outbreak, let's say of VRE. And getting access to that clinical data has proven to be a complicated issue, especially in a system where the data is not standardized and where every hospital is using a different electronic health record and different repositories to store this information. Here's an example of the kind of problems we faced when we were just going after one of the most common tests, which is just a plasma sodium. Here's an example of our first 6 hospitals, site A through site F, and showing the way that a sodium can be stored. And you can see that at some hospitals, it's just called sodium, which is easy enough. But even then, it could show up in just a standard blood draw. It could show up in a blood gas, for example, and you'd have to find all the places it could appear. But at other hospitals, it could be complex acronyms like NAPL or NA or NAS or NAV. And to find where all that information is and to bring it into a standardized repository has taken a lot of statistical innovation and manual validation. And I think a lot of the work of our team is overcoming that problem. And sometimes you can drop information without realizing it. So this is a time flow of the kind of information that's been flowing into Gemini. Looking at, for example, again, that sodium value, which is in red, the hemoglobin value, which is in green, and the blue value, which is all of our mapped lab data. And these are proportional changes. And you can see suddenly in site B, in roughly 2015, there was a drop in the sodium values. And all of you who work in a clinical environment would know that, of course, you wouldn't suddenly just stop testing for plasma sodiums in 2015. It's one of our most important tests. So what happened? So what happened here was that the site specifically had changed the coding acronym for sodiums, and they had changed it suddenly in 2015 from the word sodium to the acronym NA. And as they transferred data to us, their own internal systems flagged NA as missing data, which is often the acronym that's used in a large data repository, whether it's an Excel spreadsheet or another spreadsheet for missing data, NA. And it just gives the example of the kind of problems that can emerge when you're trying to pull this kind of information out from complex systems across many institutions. Here's another example where computational checks can detect a problem. We looked at blood transfusion timing, which is really important. For example, we're a partner to Choosing Wisely Canada, and we're looking at pre-transfusion hemoglobins and how often a pre-transfusion hemoglobin is below 70 for a typical normal risk patient. So part of that determination is looking at the timestamp of when a hemoglobin was done and when a transfusion occurred. And you can see here that a number of hospitals, we found out that in fact their timestamps had negative values. And negative values, of course, are not possible. Time zero is when a patient is triaged in an emergency room. And it highlighted a systematic error and unfortunately a non-random error in the way that timestamps were being generated at this hospital for the transfusion information. It allowed us to importantly address the fact that the hospital had some errors within its own documentation that were fixed and improved over time, but also to know that that information for that period of time was not usable for those hospitals in broad analytics. Those are just two kind of mundane examples of a larger process that we've had to go through. And this is a paper that highlights our broader statistical approach and manual validation approach for getting data out with high quality. I'm spending a bit of time on this because one of the initial barriers we faced when we started to talk about using digital clinical information for quality improvement, for research, criticisms we received from CHR reviewers, criticisms we received from frontline physicians was this kind of process is error prone. Prove to us that you can do it with high quality. The other thing that I'll highlight here in the papers that I show you today, I'll highlight trainee names. You'll see as I go through the presentation that building clinical repositories and capacity to do research with it has proven to become a major mechanism for trainee research projects. And I think it's because it very tightly matches the trainee experience. So when you're working with a trainee on the ward, you're seeing a clinical case. If that very digital information could be used then for research and analytics, the questions you're asking, is this the right antibiotic? Should we have discharged this patient one day earlier or kept them one day longer? Those kind of questions that you're talking about with your trainee can often lead into research projects. And you'll see that many of our papers, most of the papers I present today have trainees involved. So what did we find in this, or what did we generate in this kind of statistical and manual validation project for data? We found that, in fact, it can be done quite well. So we randomly sampled just over 23,000 data points from over 7,400 admissions. And we showed that through a layered approach of statistical quality checking plus manual validation, you could arrive at very high accuracy. So the accuracy of information ranging from our lab tests to physician attribution to major clinical outcomes like death or ICU transfer ranges from 98 to 100%. This is good enough that this data set is research ready and can be used for QI. And so we went and built the data repository and we expanded to more hospitals. This is a screen grab of a movie that I'm sure many of you have seen called Field of Dreams. And these are men walking out of a cornfield in Iowa. And the theme that kept going through this movie was, if you build it, they will come. And they were talking about a cornfield in the middle of Iowa, but of course, what I'm talking about is health data repositories. And what we found in Ontario is that once you build a repository that covers a lot of the population, And once you create high quality data standards, many users will come out of the cornfields. And so what we have covered here now is about 40 hospitals actually as of today that cover just over 60% of all of Ontario's medical and inpatients and ICU inpatients. We've built in REB protocols and data sharing agreements that allow rapid access. So the typical user of our data set will submit a one-page proposal. We have a project and publications committee that oversees proposals and has approximately 12 business day turnaround time for approval for a proposed project. No further REB approvals are required. So you could be a user sitting in Alberta or in British Columbia. We have a grant going in with Alberta researchers now around renal care in hospital, for example. So that one-page proposal goes in, and then you are given access by our project publications committee. No further REB is required, and you have virtual access to a high-performance computing environment. So this is an environment called HBC for Health, which sits at one of our large hospitals, Sick Kids here in Toronto. And it's supported by the Digital Research Alliance of Canada. And what it means practically is a user anywhere in the country, once they're approved, can have access to the data in a high-performance computing environment. We currently hold data on just over 2.5 hospitalizations in Ontario, and that's many billions of data points because this is really rich clinical data. And this is the they will come part of the story. We have now, as mentioned, over 1,000 active clinicians, scientists, and students using the data. We have over 100 active projects, including, I believe, 15 active CHR projects that are running off of GEMINI data. There's projects from the Heart and Stroke Foundation, from the Canadian Cancer Society, and from other agencies. And more than $85 million in competitive grants have been raised now using GEMINI. And importantly, it is a system resource. So the majority of those grants do not sit with myself or Amal Verma, the co-leads of the program. They sit at other institutions. They're people like the grant that I mentioned that's going in Alberta now around renal care, where other institutions are leading an important question, and GEMINI is helping to provide critical information about in-hospital care. We have a large team of just about 40 people now. The majority of them are data scientists, people with computer engineering or computer science degrees. We also have project managers and epidemiologists and others. So it takes a large team to keep this kind of infrastructure running. I'm going to pivot now to give you examples about how this information can be used. I'm going to use 3 sets of examples. The first is around rapid response to a crisis, and I'm going to use the COVID-19 pandemic, but think again about wildfires, about flooding, about any of the challenges that we may face going forward, and where the health system is asked to rapidly respond and provide care under high pressure circumstance. The second is around using the data for quality improvement and how we're running a quality improvement network in Ontario using this data. And the third is our first attempt at a multi-institutional AI deployment. To our knowledge, it's one of the largest or the largest multi-hospital AI deployments to occur in the country. We're looking at delirium prevention, and we're doing this across 10 institutions. So as I mentioned, clinical data repositories, because they are right at the coalface of providing care to individuals, can actually be critical in terms of health system response. Let me give you a few examples. As COVID cases were first rolling in the United States and in Europe, one of the early areas of concerns was nursing home outbreaks, and we saw this occurring in other countries. The Ontario government asked us to determine what would happen if there was rapid spread within nursing homes, which of course we ended up seeing within nursing homes and long-term care. What kind of resources would be required for the provision of escalated care within a long-term care center for patients who no longer had capacity to determine decision-making? So they had pre-specified care directives to say they did not want to be transferred to hospital. But we knew that now there was going to be a wave of infectious disease. So what would you require? What kind of intravenous fluid? What kind of antibiotics? What kind of imaging tests? What would you need? And so we looked at the GEMINI data set. We completed an analysis within 2 weeks across roughly 200,000 people to say, here's the top medications you would need. Here's the most common imaging tests you would need. Here's the kind of blood work you would need. And then with the Ontario government, we were able to stand up a program called LTC Plus across roughly 55 long-term care homes that enhanced access to this kind of acute care to sort of mirror to some extent what would have happened if these patients were transferred to hospital. And we are also able to publish this paper in CMATCH to show what kind of modeled resources you would require. A second example is questions around the severity of illness. So there was a lot of question about whether, of course, this was just the flu or something more severe. we were able to provide Canada's first estimate of what hospitalized patients would look like with COVID. We looked at a sample of hospitalized patients. We showed the severity, which at that time, pre-vaccine, was 3 times the severity in terms of mortality rate of the flu. We also were able to validate clinical prediction scores that allowed triaging of patients when they came into hospital to say, this is most likely to be a severe case, this is more likely to be a mild case, as our system was under pressure. So harnessing that clinical data to look at both severity and to triage and make decisions. A third example is critical drug shortages. So as you know, the first life-saving drug that was found for COVID was dexamethasone, which is great. It was cheap. It was widely available. But the second was tocilizumab, the IL-6 inhibitor, highly constrained, a single producer globally, and we knew Canada was going to run out. The question was, how short would we be? We were able to generate a paper for CMAJ. This provided the first estimates for Canada about how short we would be in supply, and proposed a triaging framework based on clinical severity that ended up being adopted in Ontario. This was our triaging framework, our allocation framework for when we ran out of tocilizumab to determine who would receive it. And a fourth example is the impact on highly vulnerable groups. This is a patient perspective from CMAJ by my colleague at Unity Health, Seema Marwaha. It's Victor's story. Victor is an individual with multiple disabilities, and we wondered about individuals like Victor when they were admitted to hospital, what would happen. We were able to provide Canada's first estimate to show that, in fact, patients like Victor did much worse. So we showed that, for example, independent of severity of illness, patients with disabilities, when they were admitted to hospital with COVID, ended up having higher readmission rates, higher mortality rates, longer lengths of stay. The critical point here is that it also was during the time when patient visitors were greatly restricted or absolutely restricted from hospital. And we made the argument that especially for patients with severe disability, that visitor, that caregiver, that personal advocate is often critical for providing high quality care, for advocating for good nutrition, for personal hygiene. And so by preventing them from coming into hospital, we were especially punishing people with disabilities. And this led to multiple hospitals in our province starting to loosen their visitor policies to allow that personal caregiver of someone with a disability to visit, of course, acknowledging that there was still some risk, but allowing that to balance the care quality against the risks of COVID spread. I'm going to now move on to quality improvement work that we've done using the data set. So I'm going to use the specific example of the General Medicine Quality Improvement Network. We were delighted to have the support of the Ontario government and the Ontario Health to use this data for quality improvement. And it was based first on our observations around the variation in care that was occurring on general medical wards. So general medical wards in Ontario, and I believe this is very similar in Alberta, are the largest segment of in-hospital care. They represent roughly 40% of all emergency room admissions to hospital. And therefore, when hospitals think about congestion, flow, wait times, hallway medicine, COVID pressures, often they're thinking about the general medical ward, because when this ward swells, when this ward has problems with accessing imaging or accessing other tests, that has spin-out effects across the whole hospital, and then invariably spin-out effects across the whole health system. Emergency wait times go up, access to care parameters go down. And so when we presented information about the variation in care that was occurring to the Ministry of Health and to our deputy minister at the time, there was a lot of interest in using data to help physicians understand where this variation was occurring and look for opportunities for quality improvement. And there looked like there was very significant opportunities. For example, even at a single hospital where you are admitted to one internist like me on a Monday or admitted to my colleague Amal on Tuesday, the differences in the way we practice meant that you would, for example, have a 60% longer length of stay depending on who you're admitted to. Or you would have 80% more or less, you would be 80% more or less likely to have access to an MRI or a CT scan on that admission, depending on the personal care decisions of that physician you were admitted under. So we found these very large variations. And importantly, because you don't control for most elective services, non-elective services such as general medicine, such as the emergency room, such as the ICU, we don't determine who is sick enough to get into hospital. That person comes to the emergency room, they come by an ambulance. You can hear an ambulance in the background. Sorry, I'm at the hospital. They come by ambulance, or they're brought in after a trauma. And if they're sick enough to be admitted, they have to be admitted to the physician who's on call at that time. And what that means over large samples is you get almost a randomization of patients. So if you look at, for example, the 20 internists at my hospital. I'm just going to stop to let that ambulance go by. If you look at, for example, the 20 hospital internists at on my ward on general medicine, because of this pseudo randomization process, you have statistical balance in the parameters of those patients at the time of admissions, the same age, sex, severity of admission, type of admissions. It means that if you see those large differences emerge, it allows you to think about quality improvement and variation of care, and it's not because of case mix differences. We validated this process. We validated this statistical assumption. This has been used extensively in health services research, but we validated it in a Canadian context in this paper. And importantly, it then highlighted the opportunities. So for example, these are 7 hospitals, A through G, and each bar here represents one of the staff physicians on those medical wards. And let's use Hospital D as an example. You can see that the average length of stay here, the y-axis is total length of stay. The average length of stay is about 4.9 days. But the variation between physicians is really significant. You have some physicians who have a length of stay of over 6 days for their patients, others who have a length of stay of just over 3 days. If a bar is colored, it means that this is a statistically significant difference as well. So as you can see, large differences, and they're not just noise, they are statistically real differences. And that is the opportunity for quality improvement. So we work with the Ontario government to develop a program called the General Medicine Quality Improvement Network, or GEMQuin. We deliver personalized reports to every physician now covering, sorry, another ambulance, give us one second. So we deliver personalized reports confidentially to every physician in the network now, covering roughly 60% of the province. These are called My Practice Reports. And then we have a supportive quality improvement community of practice where we meet regularly to talk about opportunities to learn from best practices, to move towards better practice, and to better understand the care we're providing as individuals. This is a screen grab of the physician report. These are highly interactive reports. There's many screens you can click through and pop-up boxes. We generate these reports. As I mentioned, they are confidential, but physicians then come together willingly to talk about how to use them to learn from the data that they're seeing. We also provide reports now for hospitals. So now hospital executives, ward chiefs, or ward directors can see differences between hospitals and say, why are we using more blood work? Why do we have longer lengths of stay? What can we learn from others? Where are there opportunities for quality improvement? And what can we share about areas that we are doing that are excellent with other institutions? So for Ontario now, this has given the opportunity in areas that were really out of sight in many ways. Physicians didn't have that personalized information about the care. Hospitals did not have that comparable information that was statistically benchmarked. Now we're providing information that allows that direction. And in Ontario, quality improvement targets for hospitals are part of their legislative requirement. They have to submit an annual plan to the government. Increasingly, information from GEMINI and from these reports are dictating what is part of that plan. They're selecting parameters based on the quality and the data that they're seeing. They're then using the reports to track improvements over time. I'll just say that in general, this process of audit and feedback can lead to positive change. A systematic review done by researchers, in fact, some of them from Alberta and some of them here, Noah Ivers, who's at Women's College, show that on average, you have a roughly 4 to 5% improvement in clinical care, but that could be up to 16% if there's additional characteristics of how that information is provided, including highly personalized information, statistically benchmarked, actionable. In other words, much of the information that we're providing, we hope will meet the parameters of what Noah and others identified as what is most likely to improve care. I'm now going to briefly give some examples around other health services type research that can be done using a data set like this. Again, when you create clinical repositories, in many ways, you don't know the ways that they're going to be applied. I use the COVID example. We didn't know that there was a once in 100-year pandemic coming when we created GEMINI, but it clearly proved to be useful in our local context. Here's some other examples, and I think we would have never imagined the diversity of examples of how this data set could be used when we originally had created it and thought about the idea behind it. I'm going to describe one example from each of these 3 buckets. So one around resource use, one around efficiency and flow, one around patient safety. I'm also going to list a few other papers just for your interest, where you can look them up if there's further interest around other ways within those buckets this data has been applied, but I'm not going to go into depth onto any of those other papers. So starting with resource use, what about antimicrobial prescribing on the ward? This was a paper that we published just in the fall of 2023, looking at antimicrobial prescribing on the wards, on general medical wards. Surprisingly, this had not been studied in any other context globally. So this was the first estimate. And we found, not to your surprise now, based on what I'm saying, we found large variations in the way antimicrobials were being prescribed, independent of case mix. So these are 4 hospitals within our network, 1, 2, 3, 4. Every dot here represents an individual staff physician, and the first row is days of antimicrobial prescribing per 100 patient days. You can see, again, wide variation between physicians, even at the same hospital, even on a balanced case mix. The second example is antimicrobial free days, which is an inverse sum ways of days of therapy. So how many days per 100 patient days was someone not prescribed an antibiotic? And then intensity of antimicrobial use is the third row. This is a high intensity antibiotic like a piptazo versus a very narrow antibiotic like penicillin. So how often are you using broad spectrum antibiotics? And you can see, again, a dramatic variation across all 3, sometimes as much as a 2-fold variation in volume or intensity of prescribing. So does that higher prescribing of either higher volumes or higher intensity antibiotics, does it improve clinical care? And the answer in an observational study like ours is no. So as you can see, if you look at the odds ratios of in-hospital death, ICU admission, 30-day readmission, or length of stay, you see no improvement if you prescribe more antibiotics, so more days of therapy per 100 patient days. And you see no improvement if you prescribe more intense antibiotics or broader spectrum antibiotics across any of those parameters. And this, of course, is a perfect environment for a randomized trial. And so we have proposed, and we're grateful to be funded in the last project grant cycle, that this is the perfect environment to randomize the provision of this information back to frontline physicians to see if you can improve care. Up to this point, this has not been tested in a hospital setting. They have shown in primary care that providing this kind of information back on antimicrobial prescribing can reduce the use of antimicrobial use, both volume and broad spectrum antibiotic use, and had no harm or detectable harm to patients in terms of clinical outcomes related to an infection. That has not been established in a hospital setting. And so this is the pragmatic trial that we are currently running, or just starting in 2024 here in Ontario. I'll just highlight that using electronic clinical data infrastructures like GEMINI can make a trial like this much larger in scale and lower in cost. We estimated as part of our grant submission that if we were to run this trial using traditional methods, manual chart abstraction, for example, this would cost roughly $5 to $6 million, would require 150 baseline charts to be audited by hand, and it would be very expensive, but not surprising as a number. A phase 3 randomized trial on average costs $17 million. So this would cost roughly $5 to $6 million to do across the province of Ontario using traditional methods. What I'll highlight, though, is that we were able to do this using GEMINI for less than $1 million, so at roughly 20% the cost. And it highlights the ability to do these kind of studies at scale on a very clinically important question like antimicrobial prescribing if you start to harness those clinical data infrastructures. Okay, so the example of antimicrobial prescribing, that's the top line here. Do physicians who prescribe more or broader spectrum antibiotics have better clinical outcomes? And the answer is no. 2 other examples of resource use that we published in the last few years. One was around echocardiogram use in stroke. We found that it rarely changed clinical outcomes. It could be done as an outpatient, enhancing patient flow and potentially getting patients with stroke to discharge, rehab faster. We also looked at PICC line placements and found that often they are placed inappropriately, especially in older patients and in women. And so again, a very actionable finding. Second set of examples is looking at efficiency and flow. This is a study done by one of our trainees who's now a GIM fellow, Emily Barsh, and Seha Shin, who's a medical student at Western University. This looked at wait times for imaging in hospitals. So this was a surprising finding. We know that there's high amounts of variability for wait times for outpatient imaging, waiting for an MRI or waiting for a CT scan. But what about in a hospital at a well-resourced hospital for acutely unwell patients, like on a medical ward who may have cord compression or intracranial bleed or any of the things that we manage? As you know, imaging is widely used. The majority of patients, in fact, get a CT scan, large amount of ultrasounds and MRI use. And here is the variability, just to give you a sense. So these are 5 University of Toronto associated hospitals, very large hospitals, very well resourced, among the most well resourced hospitals in the country. But look at the variation in wait times for things like a CT scan from as little as 10 hours at hospital 1 to more than 20 hours at hospital 3. Look at the variation in MRI wait times from little over 20 hours to more than 40 hours, and so on and so on. This was really important information. So because hospitals historically have not shared data, because the metadata around wait times in hospital has not been accessible, this was really not something that was apparent to hospital executives. And you can see that if one hospital has a long wait time for CT scans, it's not because of general shortages in staffing. For example, hospital 3 has the longest wait time for CT scans, but the shortest wait times for MRIs. So you can see this is very actionable information in terms of how you allocate your staff within the radiology department. And again, highlights the improvement, the implications for clinical care, because not only was there variability between these hospitals, there was dramatic variability on weekdays versus weekends at every single hospital. Weekends, which is in blue, had much longer wait times for imaging. These are, again, acutely unwell patients versus weekdays in red. You can see it's true in every hospital. And the longer you wait for an imaging test is a direct predictor of how long that patient ends up staying in hospital. So we, like you, have enormous pressures from government and from others around reducing our length of stay in a hospital. But what we showed here is that if you are waiting, for example, for an MRI, and those wait times could be 40 hours on average, that every hour you wait translates to a 1.6 hour increase in length of stay. So if you are waiting 40 hours for an MRI, your length of stay goes up by more than 60 hours. And so when we talk about length of stay predictors, we often pressure physicians and wards to discharge patients faster. But you can see that these important structural determinants of hospital function, like MRI access times, in fact, are much bigger predictors of what's happening with length of stay. So some patient flow efficiency transfer examples. I mentioned the wait time imaging test. We also looked at bed spacing in another study done by one of our fellows, Vanessa Zanella. We showed that bed spacing in an Ontario context, in fact, is safe. And it was a major question that was open here because we are always bed spacing because of bed pressures. We looked at resident changeover days to see whether that in fact impacted length of stay. Yes, it did. We looked at morning discharges to see whether it improves patient flows, and the answer is no, it does not. So other examples of the kinds of analysis you can do. Finally, looking at patient safety, this was an intriguing hypothesis. Samik Doshi, one of our fellows, worked on this with Amol to look at whether an acute illness event on a medical ward, a deterioration that led to an ICU admission, could trigger in an enhanced rate a second deterioration event on that same ward within a short period of time. This was an intriguing observation at a single site in the United States, but it hadn't been replicated. And we want to see across a broader network whether this phenomenon was true. And in fact, it was true. So once a single patient deteriorates on your ward, within the next 12 hours, the chance that a second patient would deteriorate goes up by between 40 to 60%. So there's a real meaningful uptick in risk of a second patient deteriorating. Now, why this occurs is a fascinating and open question. It could range from everything from resource diversion. So as the first patient deteriorates and the Code Blue team and everyone focuses on their deterioration, maybe other patients are getting sick on that ward and getting sicker, and people are not noticing until they also deteriorate and require an ICU admission. It could be behavioral. It could be a behavioral science phenomena where because you've had one patient deteriorate, you're now more likely to be worried about a second patient and call the ICU faster and get them transferred. This is an open question, but it highlights a kind of interesting phenomena and the ability to look at these kind of patient safety events. And of course, all of us consider an ICU transfer to be a major potential patient safety event if it was preventable, if it was avoidable. So other examples of patient safety events and patient safety analysis, we looked at rapid correction of sodium within hospital to see whether it was related to osmotic demyelination. You know that this is one of the biggest things we worry about. And in fact, our study showed that it was not obviously related to osmotic demyelination. And this triggered a lot of debate and a lot of letters and counter papers in the New England Journal of Medicine Evidence, which is where we published it. And then finally, we looked at the care of patients with delirium who have who don't speak English as their first language, and we showed that they were systematically more likely to be put under physical and chemical restraints. Really important question for Canada, obviously, especially given how many of our patients do not speak English as their first language, and really advocating for the need for more careful, attuned care when they are delirious, using patient translators, making sure you understand what is happening to these patients. In the final part of my presentation, I'm gonna just talk about our work with some AI deployment. We looked at the problem of delirium. This is a really important problem across the country. It affects probably about 30% of medical patients. Once patients are delirious, as you know, clinical outcomes are much, much worse, ranging from longer length of stay to increasing likelihood of dying, being in long-term care, and of course, cost of care goes much higher once this occurs. Delirium now affects 500,000 people annually in Canada. It is the most important cause of hospital-acquired harm and the only cause of hospital-acquired harm that is not consistently declining in Canada. However, measuring delirium is difficult. So ICD-10 codes that we generate in the health system only capture roughly 25% of delirium cases. In other words, 70 to 80% of all cases of delirium are missed by ICD-10 codes. This is really important because delirium is preventable in about 40 to 50% of cases with targeted resources, including things like early cognitive stimulation, getting patients out of bed, improving the sleep environment, improving seeing and hearing by using aids where needed, ensuring hydration, ensuring nutrition. So these are things that are doable, but they are very resource intensive, especially when you have constrained nursing resources and physician resources. But you don't know necessarily where to target them because the existing ICD-10 codes undercapture delirium significantly, as I mentioned, missing about 70 to 80% of cases. We thought this was a perfect opportunity to think about AI capacity. We developed a gold standard, AI impact on the system. We developed a gold standard for delirium by going through the charts manually. There's a validated process, very labor intensive, takes about 2 hours per chart. But we built a cohort of about 8 to 10,000 patients where we manually labeled where delirium was occurring. We then trained an AI algorithm with our partners at the Vector Institute and the Faculty of Engineering here at University of Toronto that combed through the GEMINI data, all of that data that's passively generated, the lab tests, the medications, the imaging. And as you know, once a delirium event occurs, there's a real characteristic pattern of response. Before a delirium event occurs, there's probably lab abnormalities and other physiologic dysfunctions. There's medications that are prescribed that are increasing risk, medications like a sedative, hypnotic, for example. Combing through this information, we were able to develop an AI tool that tripled the accuracy of delirium identification. So this tool has a 90% accuracy. It's good enough now that we are rolling it out across 10 institutions. And to our knowledge, at least in the Ontario context, but we're not aware of other examples in Canada, this is the first example of using an AI tool like this across hospitals for quality improvement. And we're just starting that process now. Okay, so I'm in the last few minutes to conclude. Electronic clinical data can be used to answer important questions about quality of care. Secondary applications of this data can rapidly allow you to address a crisis. We used the example of COVID, but as I said, and as was kindly mentioned at the beginning of the presentation, I was part of an expert panel from Health Canada. It's the only panel that's been put together by the federal government to look at our pandemic response. The report was released last week, and one of our recommendations was harnessing clinical data because the anticipation is crises are going to accelerate within our lifetime. Could be an infectious disease, it could be wildfires, it could be flooding, but harnessing health system data to understand what's happening, we think is critical. Third, as you can see and I believe every paper that I highlighted today, there was an incredible and important role for trainees, either leading projects or being co-authors on projects. We believe that clinical data repositories, because it's where you're engaging with our clinical trainees, is a really good opportunity for scholarly work. And then you can see it's a really important opportunity for collaborative initiatives. As I mentioned, one of our proudest statistics about GEMINI is that it has truly become a system resource where the majority of users, the majority of grants are institutions other than our own, reflecting its value to the system. All of this work is motivated by building towards a learning health system. You all know this quote well. This is from the Institute of Medicine, done about 2 decades ago. It's about really using the information we generate as part of clinical care to understand that care, to think about how to improve it, to evaluate our interventions over time. So where are we going? We are starting our first randomized trial. As I mentioned, around antimicrobial prescribing. We were grateful to receive funding from the Ministry of Health this spring to expand our platform to pediatrics. So we're building GEMINI Pediatrics, which will be up and running by early 2025. We're working actually with Alberta colleagues to think about something similar called Aquarius within Alberta. This will cover about 70 to 80% of all pediatric hospitalizations in the province by 2025. We're doing a multi-hospital AI rollout and trying to evaluate and understand how that can function. We're expanding our quality reporting program outside of general medicine to other wards like oncology, cardiology, and transfusions. And then a big proposal that we have that we're working with Niche and others around is about trying to figure out how to get our data lags closer to real time. And this proposal is called Vital, and this is being submitted to CFI. It's being proposed to the federal government and other places. It's really about understanding how we can pull this health system data in, but reduce the time lags and access. And this proposal is going in across multiple provinces, across Alberta, Ontario, and Quebec. I think I'm right at 10:45. So I'll stop there. Would love to take any questions. And thank you again for the opportunity. It's a real privilege. And I'll mention, oh, there you go.
Go ahead.
Oh, I'll just say I apologize for the sirens. I'm now realizing from the chat that you didn't hear them. And so I should have just kept talking.
No, it's all good. It's you did really well in terms of timing, so thank you. I actually brought Dr. Philly McAllister on the panelist view to just talk a little bit. He presented Grand Rounds I think it was a couple of months ago about AB Spore U and access to this data in Alberta, because obviously I know there's probably people in the room and online sort of just ideas churning, and learners hopefully starting to think about what's possible out there. So Finley, are you able to comment on what we're able to do in Alberta through SPORE?
Yeah. So first, Fahad, thanks. That was a great talk. And I mean, GEMINI's really come a long way since I think we met at that SGIM meeting in Toronto.
A decade ago.
Yeah. But anyway, so congratulations to you, Amol, Laurel, and everybody who's been instrumental in pushing that forward. It's really exciting to see. Just for people within Department of Medicine who are wondering, can we do this locally in Alberta? I'd encourage you to go to www.appsporeu.ca. That's the Alberta Spore Support Unit website. On there, you can actually click on data and research services. Under there, it describes the 67 data sets that we have access to through the Alberta Spore Support Unit. And there's an application form very much modeled the same as GEMINI, that people can submit a one-page application, describe what they're looking for, thanks to whoever typed it in there, probably Narman. And basically we can have access to 67 data sets, including Connect Care. With the proviso, the Connect Care access right now, we're still working through some of the bugs because we have trouble connecting between the fields, and perhaps Ross Mitchell wants to talk about that a little bit. But certainly all the other data sets that Emil has mentioned, we have access to the Alberta ones. And as Fahad has mentioned, we're doing hopefully some collaborative work between Alberta and Ontario and actually Quebec, both with Vital and with project-specific things around GEMINI. And there's some exciting work that's coming down, and there'll be another email in your inbox later today, Fahad, around the stuff with the NIH on recovery in general medicine after COVID. Well, not after, but in the endemic phase of COVID, I guess. So just encouraging department members, if you want to know more about administrative data, go to that website. There's a lot of information there. There's also some pre-recorded webinars on the different administrative health data assets within Alberta, the ways to access them. Reminder, within AppSpore there are now 18 analysts and statisticians that are assigned on a case-by-case basis as applications come in. But that's all explained on the website. So we're not quite as advanced as GEMINI. Hopefully, eventually we'll catch up to GEMINI, but this is a really exciting time for anybody interested in QI, health outcomes research, particularly in the general medicine field, but any internal medicine subspecialty. So thanks again, Fahad. Great talk.
I'll just add to everyone that all of you know better than I how unfailingly humble Finley is. 10 years ago when we had this idea, one of the first people we presented it to, we worked with Andreas Lapakis, who many of you may know, and he said, I'm going to arrange a time for you to meet Finley. And we presented the idea for Gemini to Finley and to Bill Galley. And that was really a critical starting point for us. And a lot of our early endorsement letters and support came from Finley and Bill. So it's really a delight to now present this back 10 years later.
Thanks, both of you. Go ahead, Finley.
No, it was okay. I was going to say all that Bill and I didn't do very much. It was all Fahad and all Andreas, etc.
Okay, we're going to address some of the questions. We'll start online and then see if there's anything in the room. So the first one is around the peripheral hospitals. I mean, you can read as well as I do, and whether or not you have concerns about including, we call them here hospital care teams, but family medicine units, I guess, in some of the data that you've analyzed.
Yeah, so all of our hospitals, the family medicine hospitalist teams are also involved in our data. And the majority of our hospitals, we're at approaching 40 institutions, roughly 70% of them are community hospitals, large community hospitals. The significant gap we have right now is smaller sites. There is an initiative under consideration at the Ontario government now to expand this out to 50 smaller community hospitals as well. And so we are trying to address that. But to summarize, all hospitalist-based care is included already. I think the gap that we want to address is rural parts of our province, which, as you know, in your province as well, are historically underserved, and we're working towards that now.
Thank you. And then Dr. Hayward has asked about, sort of the information that you're able to capture in terms of what's entered in. So there's so much variation, and I know you covered it a little bit at the beginning, but maybe you can just reiterate that. How have you been able to address the disease-sensitive real-time quality surveillance, and are you entering the data in a more structured way?
Yeah, so we are reliant on the way that the data exists in the system. So to your point, Dr. Hayward, the areas that are not structured is not something we can fix at the downstream receiver of that information, because that has to be done upstream. However, let me highlight a few opportunities. So as hospitals are pivoting towards more advanced EHRs, increasing amounts of that information is becoming standardized, and we're right at the coalface of trying to understand how to use it. The second is that in the time that we emerged as a platform, the digitization of clinical notes has surged. So we now hold over 10 million clinical notes. These are the notes that you are dictating as you are admitting a patient. And we're working through the process. We're working with CIHI and others now to understand how to, these are especially difficult repositories for the accidental disclosure of patient information. You can imagine that in a 2,000-word note, in the first row, you say Jack. In the third paragraph, you say 40-year-old. In the 10th paragraph, you say from, Canmore. And then suddenly there's enough information to cobble together that Jack is a 40-year-old from Canmore, and you've disclosed information. So we're working through algorithms that can strip that kind of information and find it across the clinical note. But we are close. And once that process is functional, we think a lot of that nuanced information that is not in the structured data can start to be pulled out of the unstructured text data in those clinical notes. But that is a work in progress. It's very difficult, but it's very promising, obviously, if you can get it to work. We're not obviously the only group doing this. Many groups are trying, but my point in highlighting this is that I believe 5 years from now, if we had this conversation, there would be a lot of critical information that's coming from those unstructured fields that today is still largely not used.
I don't want to put you on the spot, Ross, but this might be a good point for you to jump in if you like. So Ross Mitchell is our PhD scientist in AI and data, and as holder of one of the CFAR chairs here. So Ross, I don't know if you want to make comments at this point. No, we can't hear you.
Can you hear me?
Yes, now we can.
Okay, yeah, something happened there. Thanks, Fahad, for a great talk. Very interesting. I would add that I've been here now about 3 years at the University of Alberta, and I'm in the Department of Medicine, and my team is mostly, well, pretty much all computer scientists, grad students, and research scientists. And we have a new faculty member, Mohammed Abdallah, who came to us from Toronto. And he's growing a team as well. And our focus is really on building tools for clinicians to extract data. We do a lot of work with large language models, and we have built several tools that allow us to extract structured data from unstructured clinical notes. And we also are building a tool to anonymize both audio and text data. And we have a large collection of identifiable text data that we are getting from the United States. We couldn't get it from Alberta, of course, because they said we need a tool to de-identify data, and you're in a catch-22 where we can't give you the data that you would need to train the model to de-identify it because it's identifiable. So a lot of our work is trying to be clever and working around some of the limitations of the system and the ability to release data. But yeah, we're working quite a bit with multimodal models, using some of the new transformer models released just in the past couple of weeks to really improve and accelerate the process of optical character recognition, so we can convert notes that are technically digital, but it's really just a photograph of a page of text. We can now deal with those. And we've got projects to help with triaging, predicting outcomes, all sorts of things. I would say that one of the biggest issues we face is, even though Alberta has 20 years of data in a single data warehouse, we have enormous difficulty accessing it. Nothing like GEMINI, where your 12-day turnaround to get access in a simple application process. Some of my current projects, I've been struggling for over a year to get access to data that has already been released and used. It's just a repurposing of existing data that's extracted and anonymized. And I don't know if you've run into this, but now when we try and access data, there's a checkbox that we see that says, will AI be used, or will machine learning be used to analyze this? And we checked yes, and that triggered a year of different committees reviewing our application without giving us access to the data. So to the point that this study that we're supposed to be part of, it just sent their final notice this week that if we don't participate by the end of the month, we're out. And it's disheartening because the last time we participated in this, it got published in Nature. And so we're on the verge of not being able to contribute to a major publication simply because we checked a box that said ML will be involved. I don't know what your experience is like, or how did you get over the issues? I would say that when you gather more data in one place, like the province has done, the nervousness about allowing access to it goes up non-linearly.
Ross, thanks very much for your comments. So first, I'll mention I've heard a lot about you from my co-lead Amal Verma, who I believe has had the chance to meet you a few times now. A lot of complex issues that you've raised. I would say, I think that Alberta's consolidated data holdings represent the best opportunity in Canada for the ability to move quickly if the governance and access processes could be streamlined. So I think what you're highlighting is really a human problem. It's the technology and the consolidation has occurred, and I think we all collectively need to do a better case of advocating to political and government leadership about. I think they approach this world in a risk framing. They think about risk. And I think the risk that we need to tell them about is about the opportunities that are being missed now because of the inability to use this information. And I'll give an example of something that I think was very notable, and we cited in the Walport report, the federal panel that I was a part of, which is that the Globe's, the first estimate last respiratory virus season of the effectiveness of the influenza vaccine in the world came from Alberta. And it came from Alberta because you were able to harness your data capacity to provide an estimate of influenza vaccine effectiveness by November or December of the flu season. You were able to provide an estimate. That is incredibly powerful. So I think the opportunities and the benefits for people could be maybe something that we collectively as a community advocate more for. So there's an understanding. Now, your specific question about these checkboxes, that's troubling. I haven't seen it. So we don't have that in Ontario. So I've never seen that kind of question arise. I hope we don't start to see that here. I can imagine so many of our projects now, our major partner here is Vector, just like yours is AMI. So many of our projects have an AI component now that I think it would really muck up the works if we had to go through a second round of review or something, if just because it's AI. And I think it fundamentally misunderstands it's treating AI You know, like we used to have HIV in the Charleston score, have this enormous part of the Charleston score. It's a misunderstanding, I think, of AI and treating it as all risk without benefit, and to treat it that way.
Thank you. We are close to the end of the hour, and I know there's a couple of questions in the chat, so we'll send those along. This was really a fantastic presentation, and sort of a series of presentations that we're hoping will stimulate our learners and various faculty to think about what is possible with this type of data. So thank you so much on behalf of the department. And I do need to take this opportunity to remind everybody, next Friday is a big deal. We are celebrating our 100-year anniversary, and there's going to be an outstanding medical grand rounds with our former chairs panel, and then a full day of activities of sort of celebrating our 100-year history. So please, please, please try and come. We're not going to be, there isn't going to be a Zoom option, so it's in person at Bernard Snell Hall. And then, of course, topping off with the gala next Friday night. So really looking forward to that. And once again, thank you, everybody. Have a wonderful day.